Morning. I'm privileged to be here again to speak, and it was to have been a second part to do with intravenous therapy, but Pilar visited us at Breakspear, and she saw some of the work that we're doing with the autonomic nervous system and how we're evaluating patients physiologically, and said that she would like me to speak about this. So the thing is that we can do evaluations of chemicals, and we can do laboratory tests. These are all things that are done outside the body. But when we're actually looking at a person, obviously we can do scans and things like that. They're often, unless it's something like a SPECT scan, which can be over a period of time, we cannot see what's actually happening to the person unless you do a lot of physiological investigations. And so we are very fortunate because we can do these in an automated way, and the patients are then looked at over a period of an hour or 2 hours or 3 hours physiologically. But what are we measuring and what are we doing? And so I thought I would set the scene to say that what we're looking at is the way in which the body is using oxygen, is functioning with regard to the lungs, the heart, the tissues, and measuring the autonomic nervous system is one of the things that we do in detail. So, but Bill's been talking about providing oxygen and the microcirculation, and I think I'll go through the ways in which we use oxygen, and it's one of the mainstays of life. And yesterday I was saying that you can have too much oxygen with oxygen-derived free radicals when you're trying to detoxify people. However, you need it for metabolism. And aerobic respiration and anaerobic respiration are the two principal means of production of energy. We must be able to produce energy without using oxygen, but it's not our preferred source of energy. So it's critical to know whether the aerobic respiration is impeded by lack of oxygen for any reason. And we require oxygen for the principal energy cycle in the body. I mean, it's needed in lots of other places, but the principal one is known as the Krebs cycle. And in this depiction, I'm going to show you shortly, an E indicates the point at which energy is released. But if oxygen isn't available, then we have to use an alternative pathway, which is using carbohydrate for metabolism. And this is anaerobic metabolism. When you use anaerobic metabolism, you produce lactic acid as one of the products. It's formed from pyruvate in breaking down sugars, and it's formed when people are undertaking strenuous exercise. I mean, yesterday we watched the flamenco dancing. That man must have been producing masses of, he was so amazing. A wonderful experience, thank you. But the amount of lactic acid that's formed is 10 to 15 times more than in somebody who's not doing this sort of exercise. But lactic acid is low in fasting states and high after meals. So we're using it up quite fast. I mean, we're producing it quite fast after meals. There are two types of lactic acid production. One, when you have not enough oxygen, when there is a poisoning with carbon monoxide, when there's different sorts of anemia, when we have a condition called methemoglobinemia, when we've been poisoned, the hemoglobin can be abnormal. In respiratory failure, when there's low blood pressure, and when there's poor perfusion, and if a person is doing too much exercise. And the type B is when we're actually poisoned with different sorts of drugs and chemicals, like ethanol, fenformin, cyanide, which is present in thiocyanate in some foods, but also is present in almond kernels and so on, which is used for a purpose to make laetrile. But salicylate, various other things in patients with diabetes, liver failure, infection, when there's malignancy, and sometimes, very rarely, in inborn errors of metabolism. So those are the two sources of ordinary type of sources of lactic acid. But there is another source, which is D-lactate. And this is produced by the bacteria in the gut and following bypass surgery. We have been measuring D-lactate, and we know that D-lactate can be produced by abnormal colonic flora. It's toxic in the tissues, and it gives patients pain and muscle fatigue. But the measurement of it's got to be done very carefully, because we found when we were doing the measurements that if you actually save the sample, the person's own tissues can actually make some D-lactate, which is not in the literature. But they say that we cannot metabolize it, but we can actually produce it in some circumstances. And finally, fructose metabolism, which I'll mention shortly. So lactic acid is the product of glycolysis, and it is from carbohydrate metabolism and is in anaerobic conditions. So here's the Krebs cycle. I said I would just show this to you. It's, as you all know, it's food at the top, protein, carbohydrates, fat. It comes down here. This is the Krebs cycle. And here is the alternative pathway, where we're using the breakdown of carbohydrates to make energy. And this is the pathway which is anaerobic. This one is aerobic. So this is the one that uses fats largely, and it's our preferred source of energy to use this. Wherever you see E, energy is being released. And some carbohydrates will become fats, surplus ones become fats, and then go into this cycle. So this is man's preferred source of energy, because if we were plants, we could use carbohydrates all the time, but we're not. We are animals. We convert surplus carbohydrate into fat, and thereby condense the energy into the fats, because it's a smaller volume. Otherwise, we'd be going around like tree trunks for the amount of energy we would need in a day. So in fact, this is the Krebs cycle. So in the carriage of oxygen from the blood vessels into the capillaries, Bill showed the capillary circulation, but in the carriage of oxygen from the blood into the tissues, he mentioned it's only 4 microns diameter there. And that's because the red cell is 8 microns or more in diameter, and it's got to be squeezed through the capillaries. And as it is squeezed through, the oxygen is released, where partly mechanically, but partly from another source. And when it's released, the 2,3-bisphosphoglycerate is a substance which is made. It facilitates oxygen release, and it also can help with its transport. So as the muscles contract, the presence of hydrogen ions in muscles allows oxygen to be separated from hemoglobin. Hydrogen ions in the muscles are very important, and I'll come back to this. It's the source of NADH transfer to NADHH and so on. So I think that Marty will know a lot about this. So the point is that this is extremely important, and it's depleted in the endothelial tissues in people with fatigue. As the red blood cells, which are 8 or more microns in diameter, they go through the capillaries and they have to twist and be wrung out. They're sort of squeezed to release the oxygen. But also hydrogen ions in the muscles will allow the oxygen to be separated as well. So once they're through, the chemical and physical means of extraction of oxygen lets it get dispersed into the tissues, and then it is used there. So this substance, 2,3-BPG, has a major role in the transport. If you've got a low BPG, the enzyme may be inefficient and you'll get anoxia in the tissues. If you've got a high 2,3-BPG, you can tissue anoxia would have been there for a long time. So in a way, it's a way of measuring what's happening to the patient. You can measure 2,3-BPG. It's a very simple test to do. When the mutase, which is the enzyme, is high, the body's recognized the need for more oxygen for a long time, and therefore it's quite a useful thing for telling us that the patient's been anoxic for some time. So glucose, when it's broken down to form pyruvate and lactose, this substance, 1,3-bisphosphoglycerate, is on the pathway. It can continue to make 3-phosphoglycerate directly, but if it's shunted, it will form this one. Now, we need to know this because this one will go up in people who are in anoxic environments. If you're going up the Andes or to the Himalayas, you can get a shortage unless you have of oxygen, unless you've got enough. I beg your pardon. Unless you've got enough of the 2,3-bisphosphoglycerate, and that will go up immediately. You get into poor oxygenation. So it's a means of distinguishing oxygen delivery in the lungs to the oxygen actually that's being not used in the tissues. So using 2,3-bisphosphoglycerate as a measure is a very useful way of discriminating as to how the oxygen is being delivered. This is just glycolysis, and I'm not going to go through all of this. You'll be pleased to know it's too small anyway, but just to say that on this pathway, you can see there's glucose. It's broken down normally to fructose 6-phosphate, and then that carries on down. Fructose can be toxic, and if you've got some heavy metals, lead, in the body, antimony blocks this almost completely, 96 to 98%, and there is no way that you will use ordinary anaerobic metabolism if you have got a heavy metal burden that blocks that. And we can measure fructose 6-phosphate and tell you whether or not that person has got a blockage in this pathway. It's incredibly important to understand that these basic things of the sugars and the oxygen and carbon dioxide are important. So let's just go down here. It just goes down, and you find that you're making at the end ATP from ADP. ATP is the source of the common source of energy. But you'll see in a number of places NAD becoming NADH with an H release, and here NAD becoming NADH plus H. These are all to do with the release of energy. It's incredibly important. This is a very simple pathway we've all got to use, and we're releasing energy as a consequence of it, but the hydrogen ions are important here. So this is just to show you what the bypass pathway is. Glucose can actually make 2,3-bisphosphoglycerate. It's made as a bypass. and it can be upregulated as soon as you get into anoxic conditions from the point of view of the air you breathe. So there is increased 2,3-BPG in smokers. It's in chronic anemia, carbon monoxide poisoning, high altitudes. So you get lactic acidosis when there's poor aerobic metabolism in the tissues with fatigue and pain. And now, vascular endothelial growth factor, this is another thing that we're measuring all the time. A couple of years ago, in New Scientist, there was, in Scientific American, there was a paper on VGF which they started to measure in people with cancer, and the reason is they want good drug delivery to cancers, whereas a cancer doesn't have any normal blood supply, and so therefore it's anaerobic. So they decided they would measure VEGF, and in order to upregulate the amount of VEGF, they were trying to make people have more oxygen so they could get the drug into the cancer. But we thought, well, this is fantastically useful. We'll start measuring it in our patients because we want to know if the tissues have not got enough oxygen. So, in fact, we find that we can use these two measures. We don't necessarily always have to have the machinery and the equipment to do this, but if we have these two measures, it gives us a lot of information. However, if we have the machinery, that gives us more information. So the blood vessels can bud to produce extra capillary circulation in order to ensure that oxygen is taken into the tissues. If you've got tissue hypoxia with that capillary circulation showing that there's not enough oxygen, then the tissue lining, the capillary linings, produce this substance, vascular endothelial growth factor. And so we can measure it and find out if the delivery of oxygen across the blood vessels has not been good. High VEGF levels indicate tissue anoxia. I'm terribly sorry, I haven't got our results here, but we must have measured about 500 patients by now. And so now I'll go on to the actual physiological measurements that we do. We measure transcutaneous blood gases, and this is not the PO2 and the PCO2 that you see people being measured, when they've got a little thing on their fingers measuring the oxygen and so on. It's in fact measuring tissue levels, that capillary circulation. And so the balance between carbon dioxide and oxygen in the soft tissues is crucial to normal functioning. If you have high levels of carbon dioxide, you get an acid medium, and it's a factor in fatigue. If you get low levels, this can lead to abnormal responses in the brainstem. And sometimes people have been found to be hypoxic with very low levels of oxygen. And we measure the transcutaneous gases by a particular method. It's two sensor membranes. One is sensitive to carbon dioxide and the other to oxygen. And it's just a cup that's put onto the skin. So we can measure it across the skin. And the oxygen and CO2 escape through the skin, dissolve in this fluid, and we can then detect the gases by a sensor. And carbon dioxide is detected by a change in the pH and oxygen by its magnetic property. So here is what is being measured, and this looks like a very busy thing, but in fact the top part is all to do with heart rate, blood pressure, and so you can see up there the heart rate, systolic blood pressure, mean arterial blood pressure, diastolic blood pressure. And down here, this is the gases. And in fact, here we've got the oxygen here and carbon dioxide here. And we ask this person to breathe deeply between there and there, just deep breaths. And you can see how the oxygen went up. So the oxygen should normally be about 62 or 60, and the carbon dioxide should be about 40. In this person, there was too low carbon dioxide. I'm so sorry, it's not visible. It was 33. But I'll show you what we're showing in different patients. So this is a person, oh, wait a minute, I'll go back. So this is normal responses of transcutaneous blood gases here in a person who's got some endothelial dysfunction. We know they have because the carbon dioxide is too low. So here we are. This is one in which, here again, you've got somebody doing deep breathing. And what happens? Absolutely nothing. So this person can breathe all they like, and nothing much happens to the oxygen in the tissues. So this person has got a PCO2, in fact, of 62. She's got hypercapnia, and this is telling us that the blood vessels in the tissues are not working. So it's endothelial dysfunction. So we can do things about all of these things, but it's showing different aspects of what we can measure and how we can treat people once we know what we're looking at. And here is somebody whose oxygen is there, and the carbon dioxide is right down there. Carbon dioxide down there is 28. And when they took deep breaths, nothing much happened to the oxygen. Now this is partly, it's very important to know this because at this sort of level, this person would be one of the most seriously ill people that we see, because they would be the ones that Bill said were jerking about having sort of fits. They would have tetany. Now, how does this happen? This is the sort of person that is difficult for us to neutralize. We do neutralize them, but only once we can get their oxygen back and their CO2 back to normal now. Now we've learnt how we can treat them so that they're not suffering. So what it is that carbon dioxide is the substance which is sensed in the neck, in the carotids, and it will stimulate the brain to breathe. So if the carbon dioxide is as low as this, there is no stimulus to the brain to say breathe. And so what actually happens is that this person will not have normal breathing patterns. They will be sort of not breathing at times and then gasping for breath. This is the sort of person who at night will be jerked awake because the body will say eventually, goodness sake, I haven't got enough oxygen, wake up. And they don't have proper rest because they're being disturbed. This is the sort of person who at this level will have no energy. They will be curled up in bed all day. And it's correctable, because what you have to do is correct carbon dioxide. And I'll explain why. I don't know if we've got... yes, we have. So respiratory alkalosis, what happens is that when the carbon dioxide is too low, what happens is that bicarbonate, phosphate, and all the other bases that we need, phosphates needed for ATP, they're excreted by the kidneys. This is where I was telling you that it's so important. When the kidneys excrete these phosphates and things, because there's no need for them anymore, there's no, it's a base, it's not needed if the carbon dioxide is low. Also, hydrogen ions are not needed because they're not buffering the carbon dioxide. And so we get rid of the hydrogen ions from the kidneys. And so what actually is happening is that the kidneys have taken over the control of the body. Respiration is no longer the main focus, even though we're trying to gasp away. It's the kidneys that are behaving as though they're trying to adjust things in the interests of their person. But unfortunately, it's got to be corrected. Because we've lost the hydrogen ions, we therefore have poor endothelial function. I said that at the blood vessel walls, you need hydrogen. You need this process to be going on in the blood vessel walls for any oxygen to get across. And so it also affects beta oxygen and fatty acid, beta oxidation, and we can't even use carnitine in big doses to get them because it's blocked. So these patients are extremely ill with blood vessel damage. Every cell is damaged, every cell in the body. So because there's low NDPH, the hydrogen ions and energy are depleted. These people are lying in a fetal position and they can't do anything. They are the worst of worst chronic fatigue people, and we can get them better. It's really important because we know that once we've corrected that blood vessel damage, which we do with support for the blood vessels, but we also alter carbon dioxide. And what we do is to I've just said that actually. So what we found is that we have to use the Buteyko technique for some people, and this is where you control the breathing in a pattern where you hold the breath. But also, it's present in some people with neurodevelopmental disorders, and in a lot of the autistic children, we get a very appalling situation where they've not got enough oxygen and the CO2 is deranged. They have what's called apneustic breathing, they hold their breath holding. So this is one of our patients with severe chemical sensitivity. And here she is when she's in a state with tissue hypocapnia. She's got very low CO2 when this is happening. And it's so low that it's causing edema of the brain. The brain is being compressed against the petrous bone at the back. It happens to be more on one side than the other, and it's actually giving her ptosis. So this girl goes along like this. She doesn't know what she's doing. She's completely handicapped. We tried neutralizing her, and we're in the middle of doing so, but we can't do it without treating her CO2. And what we will do is we will put on a full face mask. There she is again, with severe endothelial dysfunction. This is explaining what is actually happening. It's regulating the oxygen and CO2. You can see here, when this is CO2 excretion by the lungs, but when the CO2 is down, we have carbonic anhydrase, which is altered, and both the hydrogen ions are excreted and CO3 excreted. The regulation in the kidneys is altered. And so what we've got to do is for 1 month, we will have her with a mask on. And this mask has got a dead space in it so that she will rebreathe carbon dioxide, but we'll also attach an oxygen to it so that she can have that to help her. And so we will improve her oxygenation and her carbon dioxide together, because if you do the oxygen without the carbon dioxide, they're worse. So have I got time? How much time have I got? 10 minutes. Oh, jolly good. Okay. So I was going to add on a bit about sleep. So just to remind you that the metabolic rate is reduced at night. Oops, I beg your pardon. Let's go back. By 5 to 25%. In many people, it's down by 25% at night. The oxygen consumption, heart rate, and body temperature decline during the first few hours of sleep. So what happens with somebody who's got hypoxemia if it's gone down by 25%? These are the people who wake up the following morning with migraine, they've got continuous headaches. They're the ones who, no matter what you do, they're staggering around with a fatigue state and headaches. So if we don't be aware that we have to alter tissue hypoxemia and alter the CO2, these are the people that we've got who, although we're doing all the other things, these are the immediate things that we have to do in the first month in order to recover people. So there are several cycles of sleep through the night, as you're aware. During the awake cycles, there are different physiological states of consciousness. The beta waves, then this is stage 1 sleep, where it's alpha 9 to 13 hertz. Then you have sleep spindles in the first part of real sleep. In slow, deep sleep, we see stage 3. This is theta sleep, stage 4, when it's slow wave, deep sleep. And this is REM sleep, when there's rapid eye movement. But I mention all this because in many of our patients, we do sleep studies, and if they've got any degree of sleep apnea, when they have got not enough oxygen being delivered, they're in trouble. So the sleep is a process by which the body, including the nervous system, has to be restored based on accumulation of evidence, because we don't have the observations of what's going on in the brain during sleep. We haven't got biopsies we can do or anything of that sort. Growth hormones released mainly at night in association with the slow wave sleep. And we have to have slow wave sleep for macromolecular synthesis and REM sleep for removing the synthetic products of slow wave sleep to maintain all the synaptic conditions. So you have to have all of these cycles going on several times in the night, 4 times usually. So if you have people with disturbed sleep patterns, and some of our patients are awake a lot, they're stimulated by their super adrenergic state with too much sympathetic drive and not enough parasympathetic. So we actually have to do something about that. Also, when we've got people who've got COMT, it was mentioned yesterday, abnormalities when they're not able to break down adrenaline, if they've got poor COMT function, this is methyltransferase, they will stay awake. They're the people who are the ones who have alpha types, who are sort of working through half the night when everybody else is fast asleep. So we've got to actually give them some B12 to make sure the COMT is working properly and get them properly to sleep. So the restoration of sleep is very important. We have to have cycling of non-REM and REM sleep. It's fundamental. Each sleep cycle results in partial restoration, and after a number of cycles you get proper recuperation. So measuring sleep and oxygen as well in sleep is very important. So here we are with sleep apnea. You get all of these things: impaired concentration, depression, unrefreshing sleep, road traffic accidents, a common cause of road traffic accidents, tiredness and all these other things, but neurobehavioral disorders. With hypopnea, it's less intense than sleep apnea. This is incredibly common in our patients with chemical sensitivity. Something has poisoned the brain and they have hypopnea. We need to get their sleep restored, and we can do it in a number of ways, but often if we do supply oxygen at night, it makes a difference. With marginal hypopnea, with frequent arousals, we'll get early morning fatigue. And during the day, narcolepsy, when you can have daytime sleep, can confused with sleep apnea. Narcolepsy is another medical condition, but what we can do is in sleep apnea, they're they have daytime sleepiness. Lots of people with a neck circumference that's more than 17 inches, they were likely to have sleep apnea. It's because they don't breathe properly. It goes in cycles. They have a long period when they're not breathing, then they'll breathe, then they're not breathing. And people with diabetes and other conditions have central sleep apnea. Central sleep apnea is due to sleep-disordered breathing. Central control of breathing is coordinated by brainstem centers which control breathing, heart rate, and other autonomic systems. When we measure our autonomic patterns in patients, we can do this sleep studies at the same time, and my goodness, the information we get about treating patients is phenomenal. So with sleep apnea, carbon dioxide levels will rise, oxygenation will reduce. Carbon dioxide produces the acid medium, and this will contribute to fatigue. And we do a polygraphic study with a nasal thermistor and doing a continuous electroencephalogram and an electrocardiogram and electromyogram all at the same time. And this is an example of apnea during slow wave sleep arousal. It's interrupting sleep, but you can see at the bottom here, this is apnea, and the person will then wake up. It'll be asleep and then wake up when there's a long enough period of apnea. So there's no restoration of the metabolic function of cells. We just also look at the blood vessels. I was talking about what's happening in the blood vessels. This is to do with distribution of gases. But what about congestion in the vessels? So we look at coagulation as a factor in perfusion. And what we've decided to measure, we can measure all these things, but in fact, the most important thing to measure is thrombin-antithrombin complexes. Perhaps I put that on the slide. But fibrin can be deposited within the capillaries, and lots of pathogens activate, lots of pathogens activate the immune system, and these include the viruses, bacteria, fungi, all of these. And we see a lot of people with Borrelia, a lot of people with EBV and the other viruses, and they are anaerobes. And what they do is they produce anoxia. Fibrin deposit around them encourages their survival, and they actually put a biofilm around themselves. So there are sort of clumps of these organisms stuck in the tissues, and you have to break the biofilm and kill the things as much as you can. But also we get immune complexes with allergens, with heavy metals and exogenous toxins. They can all activate the immune system and produce immune complexes. And Danny was talking yesterday about immunotoxicity. This is the pattern that we see in immunotoxicity. So you can do coagulation studies. They're very expensive to do. So what we've done is we don't measure the whole lot. What we've decided to do is measure one. We measure just this, TAT, thrombin-antithrombin complexes. They are high in the majority of people with chronic fatigue and with chemical sensitivity. And when we treat them, it comes down. So that's an overview of all the things to do with oxygenation, carbon dioxide, the autonomic nervous system, lactic acid, our immunotoxicity. And I'm sorry if it was all muddled together, but we find that this is so important to measure all the different aspects so that we can actually treat the individual. Thank you very much.